Hi there everybody, and welcome to lesson 2 of our CKD module. Now, with all long-term conditions, understanding the normal structure and function of the system that is affected and then how that changes with disease is absolutely fundamental when it comes to carrying out an effective patient review. But this is especially true in CKD. When we finally get to the patient assessment at the end of this module, most of what you'll need to consider during that assessment is based upon you being able to make sense of the tests of kidney function that we use in general practice. The other thing about the kidney as well is it does so much more than make urine. And when a kidney is damaged, the effect can also go beyond the kidney. So understanding the normal structure and function and then how it changes in disease, out of all of the disease areas that we deliver education in, I would say that this is up there with one of the most important. So please don't rush through this video, because what we've put in it's absolutely essential for when we get to the patient assessment at the very end. So I hope you enjoy it. And the other bit to this is, in some of our courses, we tend to do a mix of you reading and then me delivering videos, and we quite like to do the mix. But one thing that I've realised with the kidney is that it can be so complex that the best way to deliver it is really via video. Some of the explanations that are needed to make, they don't come across well in just printed word. So that's the reason why this particular module is nearly all video. So I really hope that you enjoy it, and I hope that you find it useful. So we're going to start at the very beginning, and a little bit of obvious stuff. We know that the kidneys, they're about 2 bean-shaped organs that are roughly the size of a fist, and they do differ in size in according to body size as well. And the other thing that you might notice is that the right kidney is slightly lower than the left, and that is because of the space that's taken up here by the liver. Okay, so that is big picture stuff. What we're going to do now is we're going to climb inside the kidney, and we're going to have a look at all the different parts that contribute to its function. So here we go. Inside the kidney, there's a lovely little cross section. Blood enters your kidney via the renal artery. So there it is going in. And eventually it leaves the kidney via the renal vein. Now then, there's a couple of different parts to this that are actually visible to the naked eye. You know, if this was a real kidney, you could actually see them. And so what we've got is this outer fibrous capsule, and the purpose of this is it supports the soft tissue inside, so it keeps all of this in place and intact. There's then 3 really important bits. This here is called the cortex. This here is called the medulla, and that tiny little structure there is called the nephron, and the nephron is the functional unit of the kidney. We will be talking a lot about that in a short while. So just to kind of tidy that bit up. So inside the kidney, we've got lots of these pyramid, and you can see they look like a pyramid shaped lobes. We've got the outer renal cortex, and then we've got the medulla. This is called the medulla on the inside. And what happens is blood is filtered here, and the filtrate lands within this renal medulla. And these little striations are almost like little channels, aren't they, really? They guide the filtrate into what this area here is called the renal pelvis. And what happens is the filtered urine is then filtered out of the body via the urethra. Okay. Now then, what you'll notice here is the nephron, which is the functional unit of our kidney. It actually sits between these 2 sections. So it's the glomerulus, which is where the filtration takes place, sits here in the cortex, but then the tubules make their way into the medulla. Okay, so that is a very quick overview of the insides of these kidneys. We are going to be looking in detail at the function of the nephron, because When you get to the part on kidney function tests and when you get into the patient assessment, the EGFR and the albumin creatinine ratio, which are the two main tests that we use to not only diagnose CKD, we also use it to help us classify the severity, and that's really, really important for care planning as well. All of that takes place here. So you do need to understand the structure and the function of this unit in quite a bit of detail, and that's what we will be doing. Now look at this, how amazing is our body, eh? All of the nephrons that a human kidney will ever possess in our lifetime, they're formed by the 30th week of a pregnancy. And the thing is, if we lose those nephrons because of damage or disease, there is no capacity for them to be regenerated. Okay, so by the 30th week of pregnancy, we will have had all the nephrons that we will ever possess. And the other thing about the kidney is that in childhood, the number of nephrons in the kidney, they remain constant. But after about the age of 18 years, there is a progressive decline in numbers. So that's just after the age of 18. It's estimated that about 7,000 nephrons drop out each year. I just need to mention here that we do have about 1 million nephrons in each of our kidneys, by the way. But the thing about this, and again, it's a little bit like the lung, to be honest, the kidney is, as a organ, it is so effective that we can lose a lot of its function before it affects us clinically. You know, in the lung that you can lose about half of your lung function before you start to even get a symptom. And so we don't really see the effects of this 7,000 drop every single year until after about the age of 40. Now, after about the age of 40, lung function declines progressively, and this is where the GFR comes in, the glomerular filtration rate. And this drops by about 1 mil every single year. And this is one of the reasons why, as we get older and our GFR starts to drop, we can end up with a situation where elderly patients can have an EGFR that is less than 60, but that's not because they've got a disease, it's because because of this 1 mil per year loss after about the age of 40. It's suggested now that as we get old, there are changes within the kidney, and they think that this leads to this drop off in the nephrons. So lots of things go wrong as we get old, as you know. But one of the impacts of aging is on the kidney, and that's where you kind of find this 1 mil per minute per year loss. I'll explain that in more detail, what that means when we do the module on tests of renal function. I'm going to show you how to interpret all of the tests that we use. But in order to properly interpret them, you need to understand the normal structure and function in the first place. So let's climb in and let's have a look at the functional unit of the kidney. So this here, you've got two nephrons here actually. You've got two side by side, and remember we've got about 1 million in each kidney. So within the nephron, there's two main units that you need to know a bit about. There's lots of other bits to it, but for the purpose of an annual CKD review in primary care, the two that we really need to understand about is this unit called the glomerulus and then the tubule. And again, I will be going through this in quite a bit of detail for you, but basically blood enters the glomerulus. This is like a little sieve, it's like a filter. And here is where the blood gets filtered. Now, some of the filtrate gets passed into the renal tubule, which is just here. And in this tubule, and also throughout the other part of this particular area, different substances get reabsorbed back into the bloodstream. So that is just a kind of an overview of the nephron. We're going to look at this unit here now that's called the glomerulus in quite a bit of detail. So there you go. What we've got there is the glomerulus. So we've zoomed in on that little unit. And I'm just going to very quickly take you through the gross structure of this unit. So these two vessels here, they're not two different vessels. They're the opposite ends of the same arteriole. This one here is called the afferent arteriole. And I always remember it for A for access, because blood enters the glomerulus via the afferent arteriole. And I know this might sound a little bit pernickety, A and E, E for exit, efferent. Blood leaves via the efferent arteriole. But when I show you the pathology of CKD, i.e. what goes wrong when someone's got CKD, you get changes to the diameter of these arterioles. And I know it's not really clear here, but the afferent arteriole is slightly bigger than the efferent one. And there's a reason for that. It helps with the filtration because this is bigger. When the blood comes in and it's circulating, these are tiny little blood vessels, these. Because this is slightly smaller, it provides a little bit of back pressure. And that back pressure is just enough to help to push the filtrate out through these. Can you see these little things here, tiny little slits? And it's almost like a sieve. Think about it like a sieve. I've got an image later to show you to kind of demonstrate that. Now in disease, this gets bigger and this gets smaller. And as a consequence, the pressure builds up in here. And when that happens, these little vessels can pop. And when that happens, big molecules that normally can't get out, such as albumin, they are able to escape. And then we start finding them in the urine, and that's when we know that something's not right. Okay, so A for access, E for exit. This thing here is called the Bowman's capsule. And this little bit on the inside is the Bowman's space. And the Bowman's space is where all the filtrate lands after it's been filtered through the glomerulus. And that is the glomerulus. Now what the glomerulus is, these are microscopic blood vessels. Okay, so just remember that they are blood vessels. And because they're a blood vessel, they're open to damage, like all of the blood vessels in our body. So you can get atherosclerosis, but it's not called that in the kidney, it's called something else. It's called glomerular sclerosis. But if you've got high blood pressure, that can increase the pressure within these little vessels and then they can pop. So that's the glomerulus. It's the main site of filtration. When you look at an EGFR, it's telling you how well these little units are functioning within the kidney. Now these little things here, the little purple bits, they're called podocytes, and they're really, really important. This is an image of it enlarged. So if you can imagine, that's the blood vessel glomerulus here. And these are little podocytes. And I like to think of them as like a bit of Velcro wrapped around these blood vessels, keeping them in place. They're really, really important. And one of the things that can go wrong in kidney disease is the extra pressure within the glomerulus can force these things off. They can pop. And when that happens, the vessel loses its structure, if you like. Those are the tiny filtration slits. They're of a certain size so that certain substances can't get out. One of those substances being albumin. Albumin is a plasma protein. We need albumin in our blood to keep us alive. So if it starts leaking out into our urine, that can then cause us a few problems. And this thing here is called the proximal tubule. And situate these little things here. These are little transport proteins, and these can go wrong in people with things like diabetes. The kidney is associated with hyperglycemia. That's one of the other functions that the kidney does. So that is the glomerulus and the Bowman's capsule in a little bit more detail. We will be talking about this in the next video when I talk to you about the tests of renal function, because the test that we use on the outside gives us an idea as to how well this unit is functioning. Now then, the kidney, it is such a complicated organ. Honestly, we could go on for days about the kidney. You know, it's an interesting one, is this, because we've got courses in all of the chronic diseases. And in all of the other videos that we've been making for nursing associates and also for nurses new to general practice, it's been really quite easy for us to take the content and tweak it very slightly. But I've had to completely rewrite this course because of the complexity of the kidney. So it doesn't just make urine. That's its main job. So it forms and then it secretes urine. But the kidney also produces and secretes a substance called erythropoietin, which is associated in red blood cell formation. It also produces and secretes something called renin, and that is involved in blood pressure regulation. And I touched on this on the previous slide. The kidney is also involved in the regulation of blood glucose levels, and in fact, in recent years, we've now got a class of drug that we use in people with type 2 diabetes that actually targets the defect that's gone wrong in people with diabetes that goes wrong in the kidney. But just let me to kind of take this one tiny step further. It's like all of the other organs of our body. If you damage the structure of anything, you're always going to damage the function. So if you think about the heart, if you damage a coronary artery, that is always going to affect the function of the heart. If you damage a respiratory airway, that'll affect the function of the respiratory system. And the same goes for the kidney. So when we go back up and look at this top bit, if you get some damage to the kidney, that can affect the albumin creatinine ratio. That can affect your body's ability to get rid of a substance that's called creatinine. You know, what you don't want is lots of creatinine in your blood. That can cause you all sorts of problems. But what you don't want as well is you don't want that damaged kidney to leak out albumin and proteins, because our body needs proteins. So all of these functions, if we damage all of these functions, if we damage all of the structure, you're going to see a change into the function. And this is it with CKD. When you're doing an annual CKD assessment, it's not just about looking at what's going on with your kidney's ability to form and secrete urine. You've got to keep your eye open for these other potential problems. So if we just have a look at this, one of the problems here is anemia. So part of your annual review will be checking in some people that they've not developed anemia, because that can be another sign of problems with kidney function. Renin, if we've got a defect within this can lead to hypertension. And this is one that I've just been mentioning. If the kidney isn't functioning properly, it can then contribute to type 2 diabetes. So it's a really complicated system is the kidney. And, you know, part of understanding all of this means that when you do get to do the annual review, you'll be aware that you've got to keep your eye open for this and this and this. So how do our kidneys make urine? So do you know this? Every single minute, your kidneys will be receiving over a litre of blood. And your kidneys about every day will eliminate about 1.5 litres of urine. Now remember, the content of that urine, you know, you'll have all the waste products of your body's metabolism. So 1.5 litres, it might not sound a lot, but I'll tell you what, there's a lot of work goes into making that 1.5 litres. If these kidneys couldn't work properly, if we couldn't get rid of excess water and waste products, and the biggie is this stuff called creatinine, and I'll be telling you about this in a second, we would end up with serious problems. You know, because if you've got a waste product, if your kidneys are not functioning, your kidneys are really important in getting rid of this stuff called creatinine. If your kidneys can't function properly and they can't get rid of the creatinine, then it stays in our circulatory system and then it causes us problems. So we're back to our lovely glomerulus. So here we go. If you look at this now, they're receiving a litre of blood every minute. But what happens to that blood when it lands into the glomerulus? Well, it enters, as you now know, via the afferent arteriole. And when it gets into these little blood vessels, because they're perfectly designed for the job, what they do is they start to filter out substances such as creatinine that cause us harm. Another thing to remember here is some of the drugs that we use to treat disease need to be filtered by the kidney. So one that I'm thinking about while we're just doing this little bit is in type 2 diabetes. If you've got a patient on a class of drug that's called sulfonylureas, most of the sulfonylureas, and these drugs in diabetes, they stimulate your pancreas to make more insulin. So one of their side effects is that they can make us go hypoglycemic. Now then, have a think about this. If most of those drugs are filtered out of your body via the kidney, but if your kidney's not properly working, so it can't filter out the metabolites and pass them out as urine, those sulfonylurea levels, they stay in our blood. And so therefore, people who have got diabetes and they've got CKD, sometimes if they're on sulfonylureas, that can increase the risk of them going hypo if your kidneys are not working. So that's just a kind of another example. This is one of the reasons why in some of the other chronic diseases that we're always checking kidney function. We're always, we're making sure it's not that these drugs, some drugs damage kidney, like things like non-steroidals like ibuprofen, but some drugs, the reason why we check is we need to be certain that that patient's has got a pair of kidneys that can filter out the metabolites of all of these drugs. Otherwise, if they can't filter it out, they'll stay in our blood system. And these, I mean, I've mentioned this just earlier, but these tiny blood vessels, the little filtration slits, they're absolutely perfectly designed to filter out the waste products, but to hold on to the good stuff. So if you think about it, if they're filtering out the waste, you want them to hold on to the good stuff and pull it back into our body via the efferent arteriole. So the process of making urine, the first part of that process is called glomerular filtration, and it is exactly what it says it is on the tin. It's how does those blood vessels in there filter your blood. So one way of thinking is blood comes in, but waste goes out. I want you to think about your kidney as your body's natural sieve. I think that's a really good analogy, that it kind of sums everything up. Your kidneys will hang on to the stuff that we really need, and it'll get shut of the stuff that we don't need. If this becomes damaged, this ability to filter also becomes damaged, and we start seeing signs of it in things like the albumin creatinine ratio or the EGFR. So let me show you how this works. What I'm going to do now is I'm going to do you a cross section of a blood vessel and then the Bowman's space here. So have a look at this. I know it looks a bit odd, but what we're looking at there is inside this blood vessel. And what we're looking at here is the Bowman space. What this bit here is the junction between the pair of them, and part of that is as you can see, you've got these little fenestrations, but you've got this thing here. It's like a little basement membrane. But can you see these little gaps? Well, these gaps are absolutely perfectly designed to make sure that certain substances don't get into the Bowman space, because the minute they get in there, they're going to be passed out as urine. Okay, so they're designed absolutely perfectly to make sure that that doesn't happen. So let's give you some examples. We're going to use an example of blood entering the glomerulus, and in that blood we've got some albumin. Okay, what you would like is for the albumin, just have a remember now, it's staying within the blood vessel. But have a look at this. The molecules, they're just that little bit too big. They can't get through, so they can't get into this Bowman space. And as a result, the albumin stays within our cardiovascular system, which is absolutely what we want because, that's what keeps our body going. So essential plasma proteins, they remain within the circulatory system and they keep us going. Down here, because you've not got much albumin leaking out into that urine, any urine tests that we perform, such as the albumin creatinine ratio, they will be within normal limits, because when we send these off, the labs are saying, well, how much protein's in there, how much albumin and how much creatinine's in there. But because everything's intact, we end up with nice, lovely, normal levels. Okay, so just hold that thought. What would happen if the sieve became damaged? Okay, so imagine that sieve there had little holes in it. Obviously what we'd see are the berries leaking out. Okay, so we'd start to see these berries maybe on our worktop here, eh? And we'd be thinking, hang on a minute, what's going on? That shouldn't happen. They shouldn't be leaking out of there. So hold that image. We're climbing back inside the kidney, same situation, but this time we've got a little bit of damage to the structure that separates the glomerulus from the Bowman space. And all of a sudden now, those little gaps, they're now big enough to start to let a little bit of albumin through. And lo and behold, what we start to discover is that the damage to the structure of that glomerulus is now leading to higher than normal levels of albumin leaking out into the urine. So we start seeing changes in ACR tests. But also the other thing that we start to see, damage to the structure of the glomerulus, it starts to lead to us discovering higher than normal levels of other substances in the blood. And one of the substances that I'm thinking about here is called creatinine. So let me tell you a little bit about creatinine. Creatinine is a waste product of muscle metabolism. So if we're all exercising, our muscles will be making more creatinine. And it's produced, the muscles produce it to generate energy. So it's all very normal, is this. You want for this to happen. But what you also want is you also want to have a kidney that can get shut of the excess. And this is why we focus our attentions in kidney disease on creatinine levels. So the amount of creatinine that is present in the blood or the urine is directly related to how well your kidneys are functioning. So this is why we use the albumin creatinine ratio. The EGFR is calculated according to what your blood creatinine levels are. So let's just go back to creatinine. There's our muscles. Let's pretend we've been to the gym and we've been doing a lot of push-ups in the gym using weights like you do. Well, what would happen then is your muscles would create creatinine because that's a byproduct of muscle metabolism. Now it makes sense, doesn't it, that the more exercise you do, that the more muscle that you've got, the chances are that you're going to have more creatinine. And that's something that you need to keep in mind when you are advising your patients about bringing things like albumin creatinine ratio urine samples in. But I'll tell you more about that when we do the tests in the next video. So let's have a look. This creatinine enters our glomerulus via the afferent arteriole. And what we would love for our perfectly normal glomerulus to filter any excess creatinine from our bloodstream directly into the urine so that it's not building up in our blood. And just remember that the amount of creatinine that we see in our urine sample is directly related to how well our kidneys are filtering. So what happens when you've got a damaged kidney then? So let's damage this kidney a little bit. Okay, so the kidney's not looking so healthy, but the kidney has now develop this thing that's called glomerular sclerosis. Do you remember I mentioned this a little bit earlier? And so in a way, what glomerular sclerosis is, it's almost like atherosclerosis of those microscopic blood vessels. And so the blood vessels become a bit rigid. And one example that I sometimes use when I'm teaching kidney disease is if you've ever seen how cheese is made in the old-fashioned way, where they get a big muslin cloth and it's got tiny little slits in it, and they put the curds in it, and then they apply pressure, and the pressure pushes the whey, which is the filtrate or the liquid, out of the bag, and it leaves behind just the curds, and that's how they make cheese. But they use the fabric, the muslin, for a certain reason. It's because it's got these tiny little slits in it. And in a way, that's what your kidney does. It needs those little slits to allow filtrate out. But imagine what would happen if people making cheese used a big, thick leather bag. There's no way that they'd filter it out because the fabric would just be too dense and too thick. And in a way, when the kidneys start to become sclerotic and fibrosed a little bit like this, that's the kind of same situation here. If all of a sudden those blood vessels are thick and rigid, it's going to be a lot harder for your kidney to filter stuff out. So this time it goes in, and lo and behold, it can't filter properly. And as a consequence, we start to see more and more creatinine building up in our blood vessels. I mean, the other bit to this is this could very well be a sulfonylurea, like glycoside. If you think about it, if your kidney can't filter out creatinine, it's not going to be filtering out all those drugs that need to be filtered out of our body via perfectly functioning kidney. Excuse me. And so it remains in our bloodstream. And of course, it then makes its way into our vascular system. And we start to see increasing levels of creatinine. Okay. So let me just start to summarize what we've been chatting about. That is, you're all familiar with this now. So let me show you what CKD on the inside looks like. Well, that afferent arteriole gets bigger, and now it's bigger, it can let more blood in. But remember, these were only designed to hold a certain amount of blood. That gets smaller, and as a consequence, you get a back pressure. There's more coming in, it just can't get out. And so this little back pressure here increases the pressure within these tiny little blood vessels, and they can only stand so much pressure. And then what happens is these blood vessels, like the blood vessels in your coronary arteries and in the brain and in your legs, when people have got atherosclerotic disease, they start to show signs of strain, and two different bits and pieces go on here. They get what you saw on the previous slide, which is this thing called glomerular sclerosis. But you can also get structural damage to the tiny vessels as well. So ultimately, when we talk about CKD, this here is what we're talking about. There's lots of reasons why this can happen, but in the UK, as you saw in the first lesson, the biggest cause of all of this in the UK, in fact in the Western world, is type 2 diabetes. Type 2 diabetes does to the blood vessels in the kidney exactly what it does to the blood vessels in the heart or the brain or the eyes. Type 2 diabetes, all that sugar and all that lipid and all that insulin under pressure just damages blood vessels, and it does it in the kidney as well, unfortunately. So that's what it looks like on the inside, but how would we know on the outside? Well, this is where we've got to properly, truthfully understand the tests that we're being given. So NICE guidance define chronic kidney disease as a reduction in kidney function. And the way that we know on the outside that there's a problem with kidney function is we start to see abnormalities of this thing called the EGFR. So when we look at an EGFR, glomerular filtration rate, if that is reduced, that's given us a clue that the kidney function is reduced as well. If we start to see an increase in the amount of albumin that is being passed out of here into urine, we then start to see an abnormal albumin creatinine ratio, and that then gives us a bit of a clue that there's some structural damage. When we diagnose CKD in general practice, we diagnose the presence of a reduction in kidney function or some form of structural damage. When we do that, we then have got to say which disease has caused it. And after we've done that, we now need to classify the severity of the CKD as well. In the next video, I'm going to take you through the tests of kidney function in more detail, and then I'm going to show you how to classify the severity using the test results. But it's okay for you to be able to classify it, but how can you use that? And when we get onto the patient assessment that we'll be doing, I think in lesson 3, all that you've learned in this video and in the next video, it all starts to make sense. So I hope that you found this useful, and I'm going to see you into the next video where we're going to take all of this just one little step further, and we're going to start to apply what we've learned in this session into being able to interpret and make sense of these test results, but not just to be able to go, oh, that's not right, in order to be able to say, right, it's not right, and this is what it's telling me about that patient sat in front of me, and this is now what I need to do about it. So I shall see you in the next video.